I'm Dr. Vijay Neglur from Mumbai, consultant physician and diabetologist, and welcome you all to this session 4D, which is on details, discussions, and diabetes and dialogues. And let's take few steps backwards, say 100 years back, where the life expectancy of Indian was close to just 27 years. In 2024, we see life expectancy has come to 69 years, thanks to the antibiotics, hygiene, cleanliness, and vaccination, mass vaccination, which we could achieve this. But what longevity has given to us? This longevity of survival has added global burden of non-communicable diseases like diabetes, ischemic heart disease, sudden cardiac death, stroke, cancer, and many more. And this has brought, though it is live longer, but die longer. People die longer. They suffer quite a bit, a lot of comorbidities, and therefore either they're hospitalized or they undergo dialysis, and they have a very poor quality of life. And all these diseases are driven by certain risk factors. And these risk factors are hypertension, obesity, dyslipidemia, smoking, and stress, pollution in certain places, and many more countries, and many more than this. So prevention of NCD is the important factor now, which requires a very important activity on the part of the nation and the policymakers so that we can prevent these non-communicable diseases with the correct decision to treat them early. And to dive deep into the subject of cardiovascular disease in diabetes, we have a very talented speaker, Dr. Semanti Chakravarti. So I turn this podium to Dr. Semanti Chakravarti to give her talk on the prevalence of the diabetes and cardiovascular disease in India. Over to you, Dr. Semanti.
Thank you, Dr. Negalur. Can I have the PPT, please? Today evening, our topic of discussion is prevalence of CVD and diabetes in India. Why it's important for us to discuss what are the implications on the disease-associated life years, disability-adjusted life years, what is the burden of CVD, diabetes, and CVD in diabetes. The Global Burden of Disease study in 2015 showed that there were estimated 422 cases of CVD, and it accounted for 26% of the total deaths and 13.6% of the disability adjusted life years or DALYs in India. And the prevalence in Indian population was 21.4% for diabetics and 11% for non-diabetics. It was more in the urban population as expected, and the main causes were ACS and ST elevation MI, hypertensive heart disease, and rheumatic heart disease. So why it's a matter of concern? The global burden of disease study has shown that there has been a 2.3-fold increase in the prevalence of both ischemic heart disease and stroke if we see from 1990 to 2016. There is also a twofold increase in the number of prevalent cases of CVDs when compared from 1990 to 2016. And this has put on a huge economic burden. It has been shown that the economic losses India would suffer due to CVD between 2012 and 2030 would equal to $2.17 trillion, which is huge. And a recent study from Kerala indicates that the health expenditure associated with AMI, which is now becoming more and more common even in the young population, continues to remain high in those without health insurance specifically. So what are the risk factors for developing CVD? We have smoking, diabetes, hypertension, obesity, dyslipidemia. There can be genetic factors as environmental factors. Diabetes, if we see as per the IDF, International Diabetes Federation, there were around 77 million cases in 2019, and it's expected to rise to 100.9 million in 2030 and 134 million. And Indian prevalence of diabetes is around 8.9%, which is quite huge. The burden of diabetes in India, it has been shown that the incidence of diabetic, if we compare in the world, Southeast Asia and India was 10.5, 8.5, and 9.6% in 2021. And it's expected to rise to 12.5, 11.5, and 10.9% by 2045. So the awareness regarding CVD and diabetes is very, very essential to prevent and this amount of increase. The DALI rate in 2016 was fourfold for diabetes, and when looked at the leading individual causes, it was one of the leading causes for DALIs in India. And most of the non-communicable diseases, as Dr. Negalu was saying, has gone up. And diabetes has changed its place from 35th place in 1990 to 13th place in 2016. So, what are the risk factors for type 2 diabetes in our population or in all population? If the person is having a family history of diabetes and first degree relative, if the person is having a BMI greater than uh, 23, a sedentary lifestyle, high blood pressure greater than 130 or 85, abnormal lipid parameters, have a history of gestational diabetes, age less greater than equal to 40 years, and having prediabetes in the form of impaired glucose tolerance or impaired fasting glucose. So, what are the preventive measures we can take as healthcare professional uh, to prevent CVD and diabetes? We can educate the population and create awareness about the pathogenesis of CAD and diabetes, which we are trying to do through this evening's program. We should discourage smoking and tobacco use and motivate everybody to uh, achieve a healthy diet and exercise pattern. It has been found that increasing only 500 steps per day can reduce your risk factor by 7 to 8%. And if you take 5 minutes of physical activity as per the latest ADA, where how can we can motivate our patients, it has been 5 minutes of physical activity moderate intensity per day can increase your life expectancy by 4 years. So we should motivate our patients to participate in physical activity. We should ask them to reduce their consumption of high fat dairy, carbohydrate, saturated fat, and increase daily intake of fruits, vegetables, nuts to improve overall health. Aggressive screening tests beginning at an early age around 35 years will be beneficial for early detection and treatment, and promoting healthy group exercise activities such as walking, yoga, and meditation to be practiced regularly will also help in prevention. And among the therapeutic strategies that we have in our patients for managing, we have the newer medications like DPP4 inhibitors, among which sitagliptin has shown good results in the CVOT TICOS trial. We have all the SGLT2 inhibitors, and they have come up in our armamentarium, especially in diabetes patients with a history of ESCVD or heart failure. Uh, DAPA and EMPA, CANA, all of them have shown good results. And GLP-1 receptor analogs also can be used. We have found that some combinations are specifically beneficial in Indian population because of their therapeutic benefits. Dapagliflozin added to sitagliptin have demonstrated well-tolerated profile in patients with inadequately controlled type 2 diabetes, and the combination was found to bring down HbA1c faster. Uh, so, why this combination is good? As we know, the SGLT2 inhibitor uh, increases the glycosuria. It causes a little bit increase in glucagon. The DPP4 inhibitor causes increase in insulin secretion and decrease in glucagon. Both together brings down the blood glucose level, also helps in bringing down the weight as well as systolic blood pressure. The DPP4 inhibitor, though, is weight neutral, but the combination together brings down the CV risk factor without an increased risk of hypoglycemia, and the patient is also happy after weight loss. So, uh, if we recommend this combination in our patients, we will achieve a benefit of good glycemic control along with decreasing in their risk factors. And thank you for your patient hearing.
On cardiovascular disease that we see in this country and how it is different from the rest of the country. There are plenty of questions who have come in the chat box, and I'll read for them and to seek your answer for these questions. The first question is, how have urbanization and changing lifestyle has contributed to the increasing prevalence of cardiovascular disease and diabetes in India?
Uh, Very good question, sir. I think urbanization has prevented us from doing much exercise because we are taking vehicles even for traversing short distance. Urbanization has led to change in our food habits. We the all the apps installed in us on our smartphones have made us order foods with high glycemic index or high fat content and at the slightest pretext. Also, urbanization also has its fair share of stress, which has worsened the cardiovascular disease pattern in us. So, along with the sedentary lifestyle that we as urban people are practicing, the faulty food patterns without exercise, like we are seeing cardiovascular disease even at very young age in the urban population. Also, the people are exercising, but they want to achieve a shortcut in losing weight, and unnecessary supplements have also been taken by young population, which can sometimes lead to their increase in complications rate. So in the urban population, if we promote healthy eating and healthy living, we can ask them to participate in physical activity at least 150 minutes per week. Then I think we can reduce their risk of cardiovascular complications. Also, we should try to teach them to monitor their cardiovascular parameters along with the glycemic parameters annually so that they can keep them in track to prevent the complications.
I think very good. There are a lot of influenza now, and that influenza has one which has brought in all these problems. And you can see a lot of people now have got vehicles, four-wheelers, two-wheelers. So when hardly people walk, and when they want to walk, there is no place for people to walk. The roads are so crowded, congested, so it's difficult. I think one more, two, three more important points. One is the pollution. The
Yes, sir.
pollution has contributed tremendously, and you can see the cities like Delhi or even Calcutta, Mumbai, for that matter. It is so thickly, polluted. So it's very difficult to even breathe easily in these patients. The screen addiction is also an important subject because these young people, they get addicted to screen, and there is an entity called screen addiction causing death to the suicidal conditions in these patients, also very important. And the shift workers, those who work in the odd shifts, especially those who work in the night shift, for them it is difficult because they lose their circadian rhythm, and therefore they eat at odd times and put on weight, and they are responsible at least 40 to 50 diseases because of the abnormal eating pattern by disruption of the circadian rhythm. So these are some of more important factors besides what you mentioned rightly, the eating fast food, the processed food, and which are a lot of preservatives. We don't know how safe the preservatives are.
Yes, sir.
These all
The
contribute.
endocrine disruptors
Yes,
included in those.
yes, all those are the factors which are responsible for this. Now, since you are a woman endocrinologist, and this is an apt question for you, there is a sex or gender difference between the cardiovascular disease in men and women. So how do you elaborate this aspect of the gender difference between men and women so far as the cardiovascular disease is concerned, its pattern is concerned, especially in India?
So, cardiovascular disease is more prevalent in the male population compared to the women population, especially before menopause. And but nowadays, even in women population, the cardiovascular disease is increasing. So, we have to counsel our women patients also how they can maintain a healthy lifestyle apart from their daily course. In our clinic, in our women diabetes patients, we should take a proper history regarding their family history, regarding their history of gestational diabetes, and measure their BMI. I motivate them to lose weight if they are developing pre-diabetes, which can be a risk factor, or if they are developing hypertension. We should counsel them separately, like we have different lipid targets, especially the HDL1 for men and women. We should motivate them to have their HDL at least above 50 if possible by losing weight. Otherwise, we should ask them to monitor their lipids and the sugars periodically, and to keep them the total cholesterol, the LDL below 100, or the triglycerides below 150, to reduce their risk factors. We should, in the women patients, one more thing which the patients often refuses to discuss, whether they are using ocipils, and whether for how long they have been using, and whether they have monitored their liver function or lipids periodically while taking the ocipils. We should also take history of the other metabolic diseases that can increase their risk of CV disease, like whether they are monitoring their kidney status, whether they are monitoring for non-alcoholic fatty liver, and whether they are monitoring for blood pressure. Because the women, we should also counsel them that this can be a spectrum with PCOS, GDM, and then later type 2 diabetes, which will increase their severe risk. We can treat our women patients to properly uh, control their metabolic parameters, is in order to reduce their risk factors.
Yeah, very good. I think the diabetes removes the protection women because normally the estrogen is protecting women against the infarction or myocardial infarction. But the moment diabetes sets in, that prevention is lost. That benefit of women having estrogen is lost because of diabetes. And women have more of a non-occlusive disease compared to men. That's why many times the angiograms are normal. When a lady complains of chest pain and she goes to ICU, and when the angiogram is done, invariably it does not show occlusive disease. So if women differ from men in having the coronary artery disease, which is a non-occlusive variety. There are thyroid coronary arteries, therefore women are not diagnosed. If you see any picture of ischemic heart disease, especially in Netter's book, you can see here, it's always shown as the men. Men show the chest pain, and women, when they come with chest pain, is signed off as she's a neurotic or as she is functional patient. She does not have coronary disease. So that is important that we need to appreciate that. And the drug response is also different. For example, the value trial showed that the valsartan response in women to treat hypertension was much less compared to men. So men also differ in terms of their pharmacological action or pharmacobiological action so far as the effect of the drug is also concerned. And hypothyroidism is also much more common in women. And that's why that also brings in dyslipidemia. And of course, the obesity is also much more common in women. And therefore, these women form a different set of the ischemic heart disease spectrum. And quite often it is missed because of these peculiarities in women. And therefore, there was a movement which is called Red Women Movement in USA, where they tried to bring out these points to the public that women also have coronary disease, but it has some difference compared to men. And one need to appreciate them and identify them and treat them adequately. So that's wonderful answer. Seventy, you talked a lot about combination therapy. So now we have lot of combinations, either dual drugs or a triple drugs in the Indian market, which is quite affordable because of the off-patent drugs. Then what's the place of therapy of FTC, fixed dose combination of a dapagliflozin and sitagliptin in the Indian diabetes management? How do you see the role of this combination, especially in patients of diabetes when we have combinations with sulfonylureas and of course the AGIs and metformin versus these combinations. What is your opinion?
So, most of the recent guidelines have shown us that in our management of type 2 diabetes, those newly detected as well as those uncontrolled, with the risk factor of ASCVD, the SGLT2 inhibitors have come much high up on our list. Among the SGLT2 inhibitors, dapagliflozin is one of the most affordable SGLT2 inhibitors, which has also shown CV benefits in the point of view of reduction of 3-point MACE as well as in heart failure reduction. And when we see the gliptins, sitagliptin is the one which has shown robust cardiovascular benefit among all the gliptins in the CVOT trials. So, combination of sitagliptin and dapagliflozin, if we are offering to our patients as an initial therapy or those uncontrolled as an add-on therapy, we are not only providing them a peer CV benefit, we are also helping them in reducing their risk factors of cardiovascular disease. Dapagliflozin has also shown protection in reducing albuminuria or in reducing the creatinine in long term. So, if we offer the combination, we are giving a patient a drug at an affordable price, which is controlling their sugar as well as reducing their CV risk and thus providing them a holistic benefit. It and most important in our patients, Indian diabetic patients are often not compliant with regular follow ups. If we give a combination of a sulfonylurea and metformin, we have this fear of hypoglycemia if the patient is not coming. Many of my patients haven't followed up for 2, 3 years, giving the excuse of COVID. But those on this combination, I have less fear of having a hypoglycemia or a progression in the CKD if I am giving DAPA-CETA combination compared to the other combinations.
Correct, madam. You're right. You can get the A1C reduction up to 1.5% when you use the combination. You get cardio-renal metabolic benefits. When you give the patient dapagliflozin with the eGFR of even up to 60, you can prevent dialysis to the tune of 10 to 15 years. Today, you see that what happens to the life of the patient who's on dialysis. They are miserable. You can prevent that. So that is the impact of this molecule, which can not only prevent the progression of a kidney disease, but also prevent the risk of developing need for dialysis, which is again a very important factor. Because if you ask a patient who's on dialysis, ask his quality of life, he's miserable and they get swings of sugar, swings of blood pressure, and they get infections, and therefore so many things are very common, and that is prevented by this molecule. Therefore, I think earlier you start this molecule, even the GFR is more than 60, with or without albuminuria, you get benefit. Like for example, the EMPA kidney has the group of patients who had the albuminuria were quite low, still they showed a lot of benefit. So this is an important point to understand. And secondly, it reduces the pill burden. Therefore, the adherence of treatment is better. And therefore, the patient will take the medications because it is not interfering much with life because there's no hypoglycemia as you stressed very carefully. But also important point is these two drugs have complementary action. The dapagliflozin or the SGLT2 starts working immediately as soon as you take medication. And as the glycosidase sets in, the A1C starts coming down. When the A1C starts coming down, at that time, the DPP4 kicks in. And DPP4 has dual action. One, it is glucose dependent. And secondly, it is also dependent on the EPAC mechanism on protein kinase A to form a transcription factor to stimulate the nucleus to synthesize insulin, which is not there in any molecule. So therefore, even in the elderly patient, where the beta cell mass is reduced, still the drug is effective because it has the capacity to synthesize insulin. Plus, it has a benefit to prevent sarcopenia to some extent. It also has a benefit in terms of cognitive function So you've got so many benefits across the spectrum of the age group, the young and the old. You have all the benefits. And that's why I think, despite of all the competition available, this drug should form a better molecule so far as the treatment of diabetes is concerned. I think before we close, I think there's one important last question that I would like to ask you, Simanti, because you did such a very good presentation and you walked through us all the aspects of cardiovascular disease. Suppose you are a policy maker of this country to teach all the doctors or the public at large, what would be your solution for to offer for people of NCD in general in this country if you are a policymaker? What are things you will emphasize on?
So, as a policymaker, I would try to have investments in the screening of their NCDs, especially diabetes and hypertension at all levels. Like we should encourage screening the entire population for their glycemic parameters once they cross the 35 years of age, at least every 3 to 4 years. By that, we can pick them up early, the diabetes or the pre-diabetes population. Without investment, at least we can in the primary health centers, if we keep the data on the uh, metabolic parameters like the height, weight, waist circumference, and then counsel the patients about the diet, about the exercise patterns, then we can reduce their risk factors. And when the patients are coming, all of them should have their blood pressure monitored at least, and once a year. If their lipids are also monitored, then probably we can reduce the burden of the disease. And also, if we can also devise some uh, insurance, like there are some national policies also for the uh, persons who are not seeking care because of the fear of expenditure. If we can devise some free treatment for that population, who elderly, diabetes, having other CV risk factors, how we can provide them treatment at the most affordable cost, and how we can monitor them from time to time and without causing too much of expenditure, would be one of my focus as a policymaker, how to implement these programs in their lifestyles.
Yeah, I think very good, Simanti. The best example I would like to tell you is that of Finland. If you look at the history of Finland around 1995 to 2000, the incidence of cardiovascular disease in that country was 73%. And today, what is the incidence? Is 5%. So how they could get this? How the country like Finland, with such a high burden of cardiovascular disease, could go down to so as low as 5%? They had that 6 point formula they adopted. The first, of course, is a good nutrition. So nutrition that is available to all people. For example, you see fruits and vegetables, people don't buy it because they're very expensive. It's not available easily. People buy all this fast food because it's quite cheap, and therefore the nutritious food is most important. The place for exercise, in fact, they have made a station where the staircase has a musical note. When you climb that, there's a music. A lot of people dance on that. Youngsters dance it. You see, the escalator next to that staircase is empty, and people use this more than that. So, therefore, how to encourage people to bring in physical activity? Tobacco, alcohol, of course, you have stressed adequately. Stress management, also they try to do it. Adequate sleep. We have this young generation is sleep deprived. So adequate sleep is also very important, and a healthy relationship. When you get up in the morning, you should feel, I love everybody. I like everybody. I don't want to hate anybody. So that attitude, if you have, then your cells get rejuvenated. The best example is the blood pressure. What they try to do is they got the blood pressure reduction at the community level with just 2 millimeter. You'll be surprised to see 2 millimeter mercury reduction in blood pressure. How does it has impact on the society? The impact is that once you reduce blood pressure, diastolic blood pressure by 2 millimeters, you can prevent 300,000 deaths. That's the impact. So therefore, we have to start like this. We need to have a lot of people working on this. So if you can do these 6 steps, which country like Finland could adopt, we should also be in a better position. I think it was a wonderful discussing with you, Simanti. We learned a lot of new things. You brought in the topic of cardiovascular disease, which is a burning topic, which is threefold higher in the Indians compared to Western population. We also get at a younger age, so we are 10 years younger compared to Western population. And this is the midlife tragedy that occurs, that at least 73% of people in Kerala have lost their jobs. 40% of them had to have a distress sale of their property to treat this, and 60% have lost jobs. So this was the impact of this kind of a communicable disease. Therefore, we need to step in and we need to pull our socks up and start acting so that this country will have less incidence of these diseases. Now, today, we are leading in all these factors, and these factors or these figures are not encouraging. We should not be proud of them, but we should be worried about them, and we need to take action. Do you have any final comment for people who listen to you?
So, walk more, eat less, prevent the metabolic decrease your metabolic risk factors, and thus prevent CVD and diabetes.
Sleep more and sleep more. Sleep is very important. So adequate amount of 7 to 8 hours sleep is very important. And the one who sleeps well has a very good life future. So with that, we conclude our discussion today on the cardiovascular disease. Thank you very much, Dr. Simanti Chakravarti, for your insights on this subject of cardiovascular disease in India. So Simanti, thank you very much.
Thank you.